pleasure to speak with you again, and I'll be talking about advanced CT imaging techniques for surgical planning. So this will be more of a sort of broad spectrum. I won't be focusing on the esophagus. My goals in the next 25 to 30 minutes are to provide a primer for you of 2D and 3D imaging techniques that can be helpful in your practice as thoracic surgeons, to talk a little bit about the role in surgical planning, and to describe some methods in which you may incorporate this into your practice if you haven't already. Let me begin with a little bit of a story here on why I do 3D CT imaging routinely. I had been doing it for a while, and this particular case really brought home to me why I think it is so important that it should be routine for many cases. This is a 3D CT image of a young girl. She's 5 years old, and she'd had a really difficult 5 years of life. She'd been in and out of the hospital with multiple respiratory infections, and she'd had a whole litany of tests. She'd had multiple chest x-rays, of course. She'd had multiple CT scans resulting in a cumulative radiation dose. She'd had a couple of bronchoscopies and even an old-fashioned bronchogram where they inject dye into the airways. What they knew about her was that she had bronchiectasis in her right upper lobe and that she had some unusual airway anatomy that they couldn't quite sort out. So I got a call from the pulmonologist at Children's Hospital in Boston, and he said, "Do you think you could do one of your 3D CT images?" Well, lo and behold, we did it, and we found some very interesting results, which were that as you go down, she does not have a traditional right upper lobe bronchus, and rather she has her 3 segmental bronchi all from the right upper lobe, all arising from the right main bronchus. We also discovered that the only segment that had bronchiectasis was her anterior segment. So they were able to change the surgery from a lobectomy to a segmentectomy, and she's done very well. Well, certainly, if we look to the literature, there's a lot of good reason why I, as a radiologist, should be doing 3D imaging routinely. And if we look just at the airways, which is my main area of interest, over a decade ago, it was shown that these types of images provide complementary information to the routine axial cases in about half of cases, correct actual interpretive errors in about 1 of 10 cases, and in particular for stenoses, improve the detection in about 1/3 of cases. So why am I here today saying that you should also want to do 3D imaging or have 3D imaging done for you? Well, certainly there's an article that would support this, and I think there's also a number of others and a lot of anecdotal experience. I thought this was an interesting study from UNC Chapel Hill where they compared a 2D film viewing with an interactive 2D, 3D system, and they had 23 complex cardiothoracic CT cases, everything ranging from transplantation cases to large AVMs and so forth. And radiologists and surgeons were both asked to independently record their impressions with and without the interactive system. So first they're looking at it with only the traditional 2D images and then with the 3D interactive system. And what they found was that for the surgeons, the added value was a change in surgical plan in over half of cases, increased confidence of what the findings were and what they meant in almost half, and in almost all of the cases, the 3D images correlated well with the surgical findings. For radiologists, the new findings added information in about 2/3 of cases, and I'll have to drill down a little bit and figure out why the reports only changed in 14%. I'm not quite so sure about that. But let's talk about now, as I've given a little bit of a rationale for why I think it's important to have 3D imaging routinely as part of your preoperative planning, let's talk about how that's become so easy to do. Well, we're in a new CT era with isotropic imaging, which means that no matter what plane we look at the CT scan in, we have the same resolution, and that used to not be the truth. We have improved software, and we're getting better integration. So we've really had an evolution of CT interpretation. So back when I was a resident and even a fellow reading hard copy where they would print 12 or 24 images on a page, to where now we're doing, reading at a PAC station, and we're really getting into more tailored type of imaging. This is a 3D image of the heart done with EKG gating, but looking more towards tailoring imaging, organ-specific, question-specific. So why are we trying to get away from the routine axial display as the only method available? Well, although it's been with us for a while, it's got a lot of problems. Obviously, it fragments the display of complex structures like the airway and pulmonary vasculature. We know that it underestimates the z-axis or craniocaudate extent, which is obviously very important to you if you're deciding whether something can be resected in the trachea or in terms of planning an esophageal surgery. We have trouble where sometimes nodules mimic vessels, poor 3D relationships, and there's a data explosion. As you're probably aware, when you go down to radiology now, or if you pull up a case in your office PC, you now have thousands of images sometimes from a CT, where in the past it was only about 20 to get through. So the 3D and multiplanar images help to get over a lot of those limitations. They provide a continuous display. They give you accurate information in all 3 dimensions, help distinguish nodules from vessels, clarify complex 3D relationships, and you have fewer images to look through. So a couple of myths to get through quickly. One is whether these types of images provide new data. Well, in fact, they don't. It's the same CT data that you've been used to looking at in the axial plane. It's just a complementary way to view it, more visually accessible and more anatomically meaningful. I love having an image like this. This is a patient with an adenoid cystic carcinoma of the carinal region, and I love being able to tell the story of this patient in a consult. You know, from this image alone, I can tell the surgeon the size of the tumor, the location, and the fact that the distal airways are patent. Certainly, we're going to look at the axial images as well, but this is a nice snapshot image to clearly convey the patient's disease. It's also very helpful for you if you're discussing a patient's case with them. This is much more meaningful for patients than a page of axial CT images. The other myth is that these take a long time to do, and this is just a real-time video from our institution using commercially available software, just showing you how easy it is to do this. She just chose an airway algorithm, and you'll see that up in the left-hand corner, she's just doing an automatic trimming function to get rid of anything behind and in front of the airway. In just a second, she's going to pop over to the top right corner, do a little bit more trimming. She's going to go down to the lower left quadrant. She's going to mag the image. And then just to get a better view of it, she's going to pop on it to make it go one-on-one on the screen. So just really within 30 seconds, we've got a 3D image of the trachea. It can be looked at by the radiologist, the surgeon, pulmonologist, and so forth. Well, getting back to how helpful these images can be, and I think they're important to do routinely in certain things such as the airway. This was a case of a patient with a cough, and we really didn't see much in the trachea or the bronchi on the initial axial review. There was a question of whether the left bronchus was a little smaller than the right, but it wasn't clear. And lo and behold, when we did the 3D image, there was a very long segment stenosis of the left main bronchus. You can see it's about half the dimension of the right bronchus, and it's much more irregular, whereas the right one is smooth. And this was, in fact, due to a TB stenosis. So as I've tried to illustrate in the last couple of slides, these multiplanar and 3D images help to improve diagnostic accuracy, diagnostic confidence, communication, not only between me as a radiologist and you as a surgeon, but I think in turn between you and your patients, they can be a very powerful tool. And then finally, they help with procedural planning. This is a case of a patient with an adenoid cystic carcinoma of the carina extending into the right upper lobe bronchus and with an extratracheal extension. And I can remember reviewing this case with one of our thoracic surgeons, Simone Shiku, who used to be at my institution. And I remember we went through the axial images, and he was very quiet. And then when we pulled up this multiplanar image, all of a sudden it was as though a light went off. He knew exactly how he was going to do the procedure, and it became very clear to me as he articulated it how helpful these types of images are for him as a surgeon, and how much easier it is to do his planning with these than with the axial images. So let me tell you a little bit about the types of post-processing that's available. One of the easiest, and these can be done routinely, a lot of hospitals have these, is just, we do these on all of our CT cases regardless of what they're for, is something called multiplanar reformations, and it's just taking the axial images and putting them in a different plane, most commonly the coronal and sagittal, but for something like the aorta, you're going to want to do it a little bit obliquely in what we call a candy cane view, and it just lays out the whole aorta